So a 35 years old male patient named Raja, coming from Madurai, a businessman by occupation, came with the chief complaints of abdomen pain for past 10 days. History of presenting illness. The patient was apparently normal 10 days back. He developed abdomen pain for 10 days. The abdomen pain is localized at right lower abdomen. It is gradual in onset. It is progressive and intermittent pain. And the nature of pain is colicky pain. It is not radiating, and there is no aggravating and relieving factors. History of vomiting 10 days back. And the vomiting is one episode of vomiting. It is not projectile. It is not bilious. It contains food particle. It is not blood stain. There is no history of fever, no history of altered bowel habits. There is no history of passage of blood or mucus in stools. There is no history of evening rise in temperature and night sweats. There is no history of cough with expectoration. There is no history of loss of weight, no history of loss of appetite, no history of easy fatigability, no history of jaundice, and there is no history of dyspnea. And coming to past history of the patient, there is no history of similar illness in the past. There is no history of any previous surgeries. And patient is not a known diabetic, hypertensive, or asthmatic, or pulmonary TB, epilepsy, or thyroid disorder. Coming to the personal history, patient takes mixed diet. He's a smoker for past 20 years and he smokes around 12 cigars per day. He's not an alcoholic and he has normal bowel and bladder habits. So coming to the family history, patient has no similar illness in the among the family members. So here comes our general examination of the patient. Shall I proceed with the examination?
Yes,
sir?
please. Yeah, go ahead.
Yes, sir. Patient is comfortable at rest and is moderately built and moderately nourished. He's not pale, he's not ectric, there is no sinuses, he has no clubbing, there is no pedal edema, there's no generalized lymphadenopathy. Coming to vitals, pulse rate is 78 per minute, it's a regular rhythm and normal volume pulse, and blood pressure is 130 by 80 millimeter of mercury, and his respiratory rate is 16 per minute, and his temperature is normal. So coming to the local examination of the abdomen, after getting the consent from the patient and exposing the patient adequately in his private room, on inspection, the shape of the abdomen is scaphoid, and umbilicus is normal in position and it is inverted. All quadrants moves equally with respiration. There is no fullness even in any quadrants, no visible pulsation, no VIP and no VGP, no scars, no sinuses, no dilated veins, and renal angle is free, and there is cranial orifice is also free, and external genitalia is normal. There is no fullness seen in the left supraclavicular fossa. So coming to the palpation, abdomen is not distended, and abdomen is soft, non-tender, no warm crescent, no guarding, no rigidity. On palpating the right iliac fossa, an irregular mass of size 4 cross 6 cm built in the right iliac fossa. And extent of the mass is 9 cm from the anterior superior iliac spine and 8 cm from the umbilicus, 11 cm from the right costal margin. And the mass has smooth surface and ill-defined borders. And the mass is firm in consistency. The mass does not move with respiration, but it has a restricted mobility on touching and moving. No other mass is felt in any other quadrants, and left supraclavicular fossa, no nodules is palpable, and there is no organomegaly, and the renal angles are free, and hernial orifice is also free. And coming to percussion, there is no evidence of free fluid and no evidence of organomegaly. An impaired resonance over the mass is felt. Coming to auscultation, there is normal bowel sounds are heard. An examination of the lymph nodes, there is no regional lymph nodes palpable clinically. Another system examination, central nervous system, no focal neurological deficit present. Respiratory system, normal vesicular breath zone and bilateral air entry is equal. There is no added sounds. Cardiovascular system, S1 and S2 here and no murmurs present. So diagnosis, and coming to a differential diagnosis of appendicular mass or ileocecal tuberculosis. So
That is a nice and concise presentation. I found that you had mentioned all the positive as well as the negative questions that can be asked for an abdominal
yes,
examination.
yes, sir.
Now, the only little points that I have is one, you have said that there is the mass has a smooth surface, right?
Yes, sir. Yes, sir.
And you are able to make out all the borders, right?
Yes, sir. Yes, sir.
What is that minimal mobility you're talking about?
Sir, restricted
Transverse, is it
mobility will be,
anterior posterior, is it cephalocaudal? What is that mobility?
sir, mobility is not clearly defined in this case, sir. It is
Is
partially
it
a
a
respiratory.
is it fixed or is it mobile?
Yes, sir, but it does not move with respiration, sir. But on
Yeah, one thing,
palpation,
doctor, please remember, whenever you can feel an upper border clearly and there
yes,
is
sir.
a lot of gap between the costal margin and the upper border,
Yes, sir.
don't commit yourself to movement with respiration.
Okay, sir.
Generally, this happens at umbilical and infraumbilical masses. The only
Yes, sir.
fight is between whether it is intraperitoneal or retroperitoneal.
Yes,
Okay.
sir.
You have some very nice birds next to you. Man, chase them off. All the
Sorry,
time.
sir.
Anyway,
Yes, sir.
so the if it is mobile, you should
Yes,
tell
sir.
us what plane it is mobile in. Is it transversely mobile, that is from side to side? Is it cephalocaudal mobility, which is very rare? And or is it moving anteroposteriorly, like if it is retroperitoneal, like a kidney, sometimes you can get an
Yes, sir.
anteroposterior. So if there is some form of mobility, you're almost surely going for an intraperitoneal diagnosis. If
Yes,
there
sir.
is no mobility at all in a mass at the level of umbilicus and below, it goes
Yes, sir.
very strongly in favor of retroperitoneum. Okay.
Yes, sir.
So this mobility, what are you saying? Is it transversely mobile? Can you
It
move
is
it a little?
transversely mobile, sir.
So it is moving from right to left. That's
Right
what.
to left direction. Yes, sir. Lateral to medial direction.
Very good. And
Yes.
is it painful on movement?
No painful, sir. No, it is not tender, sir.
It's not tender. So
Yes,
when
sir.
you move it also, he doesn't have pain.
Yes, no pain, sir. It doesn't complain about any pain, sir.
Okay. The second question got to ask is, what do you define by colicky abdominal pain? What is the definition of colicky abdominal pain?
So it is a pain due to a solid pain from a solid organ, sir.
Hi, hello. Colicky pain is hollow
Sir.
organ, man. Huh?
Oh,
Hollow
sir,
organ,
it is more common.
whenever there's obstruction to lumen of a hollow organ, biliary tract, urinary,
Yes, sir. Ureteric calculate.
and a hollow
Yes, sir.
organ like the intestine, you get colicky pain, a pain that comes, has a crescendo increase, becomes high, quite severe for some time, and then automatically reduces. So that is the
Yes, sir.
definition of colicky pain. When you talk of
Yes, sir. Okay, sir.
intestinal colicky pain, please ask which direction is that pain moving. Some people will tell you it is moving
Yes, sir.
from left to right. They can feel it, or
Yes, sir.
upper abdomen to lower abdomen. So that will give you an
Yes, sir.
idea of whether there is an element of obstruction or not. Okay.
Yes, sir.
If some people give it to you, it's a good, but you should ask and you should look for it. You should, leading question,
Direction
is
of
it
pain.
direction
Yes,
of
sir.
ureteric colic? It goes from loin to groin.
Going to groin. Yes, sir.
Biliary colic can go down to the back towards the on the right side towards the lower angle of the scapula. Like that, you can get
Yes, sir.
intestinal pain, giving you some idea that there is a block in the lumen of the
Yes, sir.
intestine. And since most common blocks are in the right iliac fossa region, in the ileocecal regions, some patients give it to you
Yes,
that are moving from right left to right. Okay, those are the only two things I
yes, sir.
have. Did you do an internal examination on this patient? PR.
Internal.
Did you do a
Sir,
rectal
PR
examination?
should be done, sir, but I haven't done.
You haven't. Yeah.
No,
Please
sir. I just
remember that it has
yes, I
to be.
haven't done, sir.
Yeah, it has to be
Yes,
done.
sir.
What will you do in a rectal examination? How do you do a
So
rectal
after
examination?
getting the consent,
Yeah.
so after
Yes.
getting the consent of the patient and ensuring his privacy and
Hmm.
adequately exposing the patient will be asked to lie down in a Sims position
Correct.
and so
Yeah, go ahead. Yes.
yes, and I'll just palpate. I will apply a lubricant, sir.
Before you apply
my
lubricant
finger.
and
I'll apply
palpate,
adequate lubricants.
no. Hello. Before you apply anything, first you
Sure.
inspect. Always remember in rectal examination, first look at the
Of
orifice.
inspection, sir. First, initially we'll do inspection.
What
Yes,
if
sir.
he has a fissure
And we'll
and
look
just
for any sinuses, any. Yes, we'll look for any
yeah,
fistulas or any sinus opening is present, and any skin tags are there, any warty lesions are there. You should look for it, sir. And any discoloration and signs of any inflammation are present. You should look for it, sir, in inspection.
Why
And
is
any
it
mass.
important in this case? Why is that inspection important? What is your differential diagnosis? Appendicular mass, ileocecal tuberculosis. Is there anything else you can think of? Short history?
You can go for any intussusception, sir. Idiopathic
Okay,
intussusception.
intussusception, yes.
In case of chronic or prolonged intussusception, you can even feel the mass in the rectum. Tip
No,
apex can
that
be
is
seen
in
in
the
the
very late stage. Remember, you can also get anorectal lesions in forms of inflammatory bowel disease. So
Yes, sir.
Crohn's and other things. Of course, the history is much longer, in which
Yes.
case your inspection of anorectal region is important. Understand? It's not relevant in this case, but it is important for you to remember to do it. So
Okay, sir, sure.
this is a mistake many PG make in the exam. When we ask you how you do a rectal examination, everybody says position and all that, take lubrication and push the finger in. No, you have to first inspect, you have to
Inspect.
see,
Yes, sir.
and you have to make sure the patient has no local lesion and no fissures so that he'll allow you a comfortable examination. And then you proceed by inserting
Yes,
a
sir.
finger. Look for fecal staining,
Okay, sir.
look for blood staining around the anal orifice, which gives
Yes,
you
sir.
some idea of what is happening. Okay, right.
Yes, sir.
Lastly, you said no regional lymph nodes palpable. Which
Yes, sir.
regional lymph nodes are you looking for? In the abdomen, which
Sir,
are
go
the
for
regions?
inguinal lymph node palpation.
Why did you go to the inguinal lymph node?
Sir, depending upon
Is it intra-abdominal or
there
is
are
it the
two
normal
groups
wall?
of inguinal
The mass.
intra-abdominal, sir.
So once you have intra-abdominal pathology and you're fairly sure it's intraperitoneal,
Yes,
the
sir.
only regional nodes are pre-aortic and para-aortic lymph nodes. Okay. So don't
Yes, sir.
use that
Okay,
word.
sir.
What I'm trying to say is don't use the word regional lymphadenopathy. That is only for the periphery
Yes, sir.
coming towards the center. But when you have in the center itself, your lymph node enlargement is within that cavity only. Okay.
Yes, sir.
Okay.
Sure, sir.
Why do you say appendicular mass?
Sir, patient has history of abdomen pain for past 10 days, history of vomiting on episode initially, sir. And
But no
most
fever, no bowel
common
disturbance,
thing in
nothing.
our place is appendicular.
Okay, but he didn't give any migrating pain history, nothing,
No,
no?
abdomen pain for past 10 days, sir.
Yeah. Secondly,
Yes, sir.
remember this mass is away from the anterior superior iliac spine. You said it is 9 centimeters away, isn't it?
Yes, sir. Yes, sir.
So most appendicular masses abut the anterior superior iliac spine and the groin crease area. They go towards the groin crease. The mass, the classical mass that you map out will almost always
Yes, sir.
be from the anterior superior iliac spine. So that's a very big point against an appendicular lump. However, the position of appendix can vary and it could
Very.
also be an appendicular lump. What makes you say
Yes, sir.
ileocecal tuberculosis?
And in our country, TB is the most common. TB is more common, sir.
Okay.
And the patient may have intestinal abdomen pain, maybe also due to TB, sir.
Okay, but only 10-day history, no? Usually it's longer.
Yes, sir.
And for abdominal tuberculosis, most patients will have a history of three things: loss of appetite, loss of weight, and easy fatigability. They need not
Yes, sir.
have fever.
Okay,
Fever
sir.
and evening rise is more in pulmonary and lymph node tuberculosis. Abdominal tuberculosis, you find, especially intestinal, it will be loss of appetite, loss of weight, and easy tiredness. Okay,
Yes, sir.
that's more in favor of it.
Yes, sir.
So, what will you do, man? Patient is sitting in front of you now. So put on his clothes and he's come back to sit in front of you. How will you evaluate him?
So now I go for a routine blood investigation, sir. Like
Like,
complete blood count, hemoglobin level, and total count and differential count, sir.
why is
And total count
hemoglobin important in
to
this
rule
case?
out in case of infection, any infection, that will be total count will be elevated, sir. And differential count will be if
No,
any
I asked
lymphocytosis.
1 minute. I asked you, why is hemoglobin important in this case?
See, in case of chronic tuberculosis, that may be anemia, sir.
No. Yes,
And
I
even
know.
this mass can even be an any tumor or even any tumor can also be present like abdominal mass, sir.
Yeah, in the right iliac fossa, remember
Yes, sir.
one of the presentations of carcinoma cecum is
Cecum.
silent.
Yes, sir.
Anemia, asthenia, and anorexia, they can be very quiet. And the
Yes, sir.
only feature may be an anemia. Now,
Yes,
if
sir.
fellow's HB comes back as 5 or 6,
Yes, sir.
hemoglobin, then you have to open your eyes and think of carcinoma cecum.
Carcinomas.
So
Yes,
don't
sir.
forget, you must know routine investigations. Even in routine investigation, you must know the exact relevance of each of the investigations you're doing. Okay.
Yes, sir.
Yes,
Sure.
and if there is infection and if there's appendicitis, you may get a raised throat count
Yes,
and
sir.
you may get a little more polymorphs. Is an
Yes, sir.
ESR important?
Of course, ESR is more important in case of any acute inflammation and even tuberculosis. ESR will be elevated. So,
How much?
so around about 200 is considered to be a significant value, sir. Now,
ESR 200.
yes, sir.
Hey, hello.
Sir.
ESR will ESR values are between 10 and 50, maximum 80.
Sorry, sir, I think I am confusing with CRP, I suppose, sir.
Yeah, ESR. That's ESR. ESR. Don't worry. See, you are all modern fellows. CRP and LDH and all that you will know.
Sorry, sir.
Please
I
remember.
think I confused with CRP, sir.
Yeah, fine. All right. No
Yes, sir.
problem. I understood. That's why I'm saying.
Yes, sir.
So please remember an ESR which will be moderately elevated, say between 20
Yes, sir.
to 35, like that. You do not get very high ESR. Okay. What
Yes, sir.
next? After blood count, what else you'll do?
Sir, we'll go for a radiological investigation, sir.
Okay.
Abdomen X-ray will take for the patient, sir. And we go
What
for
will
ultrasound abdomen.
abdominal X-ray give you, man? Is this an acute abdomen?
No, sir, but in case of any intussusception or any partial obstruction, you can get some air fluid levels. Multiple fluid level can be seen, sir.
Is this an acute case or not?
Not an acute case, sir.
Then how you'll get fluid levels?
Sir.
See, you get yourself caught, okay?
Yes,
The
sir.
acute nature, severe pain, colicky pain, still vomiting, then you will ask for an erect abdomen or even supine abdomen to look for signs of bowel obstruction. Here,
Yes, sir.
he is passing motions. He
Yes,
is
sir.
not distended. And he
Yes,
just
sir.
vomited once 10 days ago. So the
Yes, sir.
relevance of an erect plain X-ray is not there. If you insist on doing it, what is the other finding that may lead you? Can there be any calcifications which will help you?
Yes, sir. You can go for any appendicular lip, anything can be.
One, yes.
In
Very
chronic cases.
rarely an appendicular less than 10% of cases you can get. Secondly, you can get calcifications in the mesenteric lymph nodes, just above tuberculosis. Okay. You can get a
Yes, sir.
mesenteric lymph node mass that will give.
Yes, sir.
All right. Anything else?
So you can go for a next ultrasound. Ultrasound can be done, sir, for the patient to find out the cause.
Yeah, these are the three basic things that one would normally does. You do the basic blood workup and you do some form of imaging, and the imaging is ultrasound. Before I go to that, I would like to expand on this differential diagnosis to get more things into your mind.
Yes, sir.
One you mentioned intussusception. Is there any other condition that this case could be?
Yes, sir.
What? Which other condition?
The CA-cecum, intussusception, and the appendicular mass
Yeah,
or abscess.
very fine. I agree. But the mass is towards the umbilicus. It's away from the actual right iliac fossa, isn't it? It's a
Yes,
right
sir.
lower quadrant mass, not a full right iliac fossa mass. So,
Yes, sir.
and it has a smooth surface.
Yes, sir.
And there is some restricted mobility. So, what else can it be? Whenever there is a mass that is arising and going towards the umbilicus in location, don't forget mesenteric lymph nodes. This could be a lymph node mass. It could be, it's a short history.
Yes, sir.
Okay, either lymphoma or tuberculosis
Yes, sir.
itself giving rise to
Yes, sir.
lymph node mass. Huh? So this is an important
Yes, sir.
differential that you must keep in mind. 4 or 5 conditions are
Okay, sir.
very
Yes.
sure. CA-cecum kind of ruled out, appendix kind of ruled out. It is between ileocecal tuberculosis and lymph node mass. For that, your imaging is important. Okay. You followed what I'm saying?
Hello, sir.
Hello.
Yes, sir. Hello, sir.
Do you follow what I'm saying?
Yeah, yes, sir. I can follow you, sir. Yes, sir.
Okay. So what is the ultrasound going to tell you now?
Sir, in ultrasound can go for appendix, sir. Any
Yeah,
appendix is present or not, we can do it. And any
okay.
free fluid in the abdomen, you can go for it, sir.
Yes.
And any organomegaly can be seen, sir.
Okay.
And urinary diaphragm can also be seen in this case, sir. And any
Again,
localized
doctor,
collection can be
see,
seen.
this is not an acute abdomen. You said it's a soft abdomen, all quadrants moving. Why you go and say air under diaphragm now? That's all
Sir.
very silly. See, the basic idea of ultrasound is to give you an anatomical diagnosis and, if possible, a pathological diagnosis. So the appendix will tell you what the nature of the mass is and from which organ it is coming, roughly bowel mass or mesenteric mass or lymph node mass. Secondly, it will also tell you the other things in the abdomen, the status of liver and spleen, presence and absence of other lymph nodes, and free fluid. These are the things that are asked for. No,
Yes, sir.
these are the things that will give us information to plan our treatment.
Yes, sir.
Okay.
Okay, sir. Yes, sir.
All right. So, did this patient have an ultrasound done?
Yes, sir. Ultrasound done. So, and
Can you read out the report? Do you
sir,
have it?
I don't have a report by now, sir. It was a case of appendicular mass, sir.
The ultrasound told you it was appendicular mass.
Appendicular mass, yes, sir.
Right. Okay. And anything else? The lymph nodes.
Mesenteric lymph nodes, I have mentioned, sir. About two mesenteric lymph nodes are seen.
Okay. Yes.
And no free fluid has been given in the ultrasound, sir.
Right. The absence of lymph nodes and absence of free fluid make this diagnosis go away from tuberculosis. But
Yes,
in ileocecal tuberculosis, you need not get ascites. Okay.
yes, sir.
Get a bowel mass with some other features in it.
Yes, sir.
All right. What else you want to do? Are you convinced? Are you happy that this with this ultrasound, or you want to do some more tests?
Sir, from ultrasound, we are coming to conclusion of appendicular mass, sir. If we need, we can go
Okay.
for even CT abdomen, sir. But I'm convinced with it, and I will just start treatment for the appendicular mass.
Okay. So since it was a short history and
Yes, sir.
the ultrasound has suggested appendicular mass, you are
Yes, sir.
justified in continuing. But if you are want to really evaluate further your next investigation, will you do a colonoscopy or will you do a CECT?
CECT, sir.
Why not colonoscopy?
Sir, in case of CECT, you can do it any, you will give some oral contrast, IV contrast, and the rectal contrast can be given so that the J fully can be screened clearly, sir.
Remember again, when somebody has told you there's acute pathology in the right iliac fossa, like appendicitis, invasive
Yes, sir.
procedure is not ideally recommended unless it is really necessary. The
Yes, sir.
imaging is the next invention. So a CECT with all the contrast everywhere can be done to see, get
Yes, sir.
further information.
Yes, sir.
Actually, a simple CT, non-contrast
Yes,
CT,
sir.
the plain CT itself will give you enough information. You need not do the CECT for appendicular pathologies.
Yes, sir.
Okay. Yeah, plain CT is enough. Plain
Yes, sir.
CT is good enough, especially when you're having doubt between ureteric calculi and appendix and other things. Plain CT is much better than a CECT. Okay.
Hello, sir.
Yes.
Sir, I couldn't hear you, sir. Hello.
Hello. Can you hear me now?
Yes, sir. Yes, sir. Now I can hear you, sir.
I told you that even you need not do a CECT. A plain CT picture is good enough for diagnosis of acute
Yeah.
appendicitis, where you'll see a mass effect, where you'll see
Okay, sir.
fat stranding, you see evidence of
Yes,
some collection and other things. That itself is good enough for your confirming your diagnosis. What will
yes,
you
sir.
do for this patient?
So in case of appendicular mass, if patient presented within 48 hours, we can even try for surgery, sir. But as a patient has presented late and
Yeah,
there is no acute symptoms, I will go for a conservative line of management, sir.
yeah. Yes, that is the correct dictum. If it is within 48 hours and there's a mass, you can probably do it. Again, today they say it depends on your skill. You can tackle any form of appendicular disease at any time. But in the standard teaching, it is that if the mass is already formed and it is a few days late, it is
Yes,
better, it is preferred, it is advised to go in favor of a conservative line of management.
yes, sir.
So
It is
how will
told
you,
that
sorry?
sir, it is told that the recurrence rate of acute appendicitis is less than 10%, sir.
Yeah.
So we did not perform any appendectomy if the patient is asymptomatic, sir.
Yeah, I'm coming to that. I will do that. I'll come to that. Yes,
Yes,
we
sir.
do a conservative line of management. I didn't say interval appendicectomy. I've said
Yes, sir.
conservative. What is conservative management? What all
So,
will you do?
so we'll hydrate the patient with IV fluids, and analgesics will be given to reduce the pain of the patient, and antibiotics can be given, sir.
Which is your antibiotics of choice?
So we'll go for cephalosporin. The third generation or fourth generation cephalosporins are advised, sir.
Why
Like
third and fourth, man? Is there any complication?
so it will be a broad spectrum antibiotics, sir, more towards gram positive.
Okay, if you use broad spectrum, I'll keep quiet. But why fourth generation and all? Just keep. You see, this is the problem. You all use unnecessarily high antibiotics for these simple conditions, and then you induce antibiotic resistance. So it is important you use a simpler antibiotic. Second generation cephalosporin with what?
With metronidazole can be given.
Metronidazole is the important
Yes,
antibiotic
sir.
that needs to be given. What is the dose of metronidazole?
400 milligram TDS can be given, sir.
As a tablet?
Yes, sir. In case of IV and IV, you can go for 500 milligram IV TDS, sir.
Yeah. It is preferred that the first 48 hours of
Yes, sir.
appendicular treatment, appendicitis treatment, appendicular conservative treatment is by intravenous antibiotics.
Yes, sir.
So you give the cephalosporin and the metronidazole intravenously for 48 hours, and then you can switch to oral.
Yes, sir.
Okay. What is the other thing? What is the main thing that you will do in conservative management?
So the patient will be kept in Ilper oral, sir.
No, he's not vomiting. You can have some oral fluids.
Sir.
What is the
Antibiotics and
main thing?
analgesics to reduce the pain, sir.
Okay, he is not having pain. What else? Have you seen the picture in Bailey and Love? What do they do? Conservative management.
IV fluids, sir.
Please remember, doctor, you have to draw out the map. Map
Yes, sir.
the
I have to mark the appendicular mass.
swelling on the abdominal wall.
Yes,
And
sir.
you have to see that there is clinical regression of the swelling. Then you know
Yes, sir.
your conservative management is working.
Effective or not? Yes, sir.
In conservative management, that is the mainstay. You will not
Yes, sir.
operate, but your only indication of what is happening inside is the size of the mass.
Mass.
So you
Yes, sir.
need to mark the mass out on the abdominal wall. So 5 things in conservative management: restrict or replace IV fluid, restrict oral or replace it with IV if he's vomiting, use of an IV antibiotic, bed rest.
Yes,
Patient should be at bed rest. It's not that he walks around and moves around. He should be at bed rest.
yes, sir.
You should map the mass on the abdominal wall, and you give IV
Yes,
antibiotic. So these are the 5
yes,
things that Oshna Sharon used to do long ago. Those words are not used nowadays. But these are the 5 components of conservative management of an appendicular mass.
Yes.
Now, tomorrow you come back to the patient.
Yes, sir.
Mass has increased in size and the patient has had a spike of fever. What is happening?
We should rule out appendicular mass turning into appendicular abscess, sir. We'll go for a repeat ultrasound to find any abscess collection is there or not, sir.
Nothing, no change. Ultrasound cap says no change. A little bit increase in size. What will you do?
So we will go for ruling out any other etiologies there, sir.
Like
Any abscess at any other site, like psoas abscess, something like that.
Okay.
Any other systemic infection to the patient.
Okay. Right. There is one little comment that has come up. Somebody said that it is expectant treatment and not conservative treatment. I apologize. You can use both words. The older term was conservative. Today they say expectant because you want to see, you can't expect. It is also the right term. Perfectly all right that you should mention that this treatment can be an expectant line of treatment or what is called conservative in the olden days. A point accepted. Serial measurement of the mass has been asked for. Yes, I'm telling you that is an important aspect of this treatment. I'm just taking you towards the progress of the lesion. If the mass reduces in size and the patient feels better and feels hungry, then you know you're on a winning side and their inflammation is getting controlled. But sometimes the mass starts increasing in size. So that's what I'm asking you. So now, if you have the mass increasing in size and on the first day, you don't do anything. But if the mass increases in size for 3 days, 3 continuous days, that is 48 hours or more, and the patient develops tachycardia with fever and other things, then you know that there is actual free pus available for you to drain, and you may have to think in terms of a surgical drainage of the abscess.
Yes, sir.
Okay.
Sure.
Now,
Yes,
what
sir.
is this? Unfortunately, this fellow develops an appendicular abscess and it becomes a little bit collection. There is no evidence of peritonitis, but he has this collection and he becomes tender. How will you treat it?
Initially, you can go for intervention radiologist management, sir. You can train under ultrasound guidance, sir. You can try for it to avoid the spillage into peritoneum, sir. Or else you can try for extra peritoneal drainage, sir.
Generally, the approach is now today we have image guided approach. You can stick a needle in and you can put a drain inside and drain. But in our days, we used to do the extra peritoneal approach. That is, go from behind and drain it directly out without entering the or spilling into the peritoneal cavity. Okay.
Yes,
if you're doing image guiding drainage, what size of the drainage tube will you use?
So you can go for 16 size, 16.
What material? What is the type of tube? Will it be pigtail or Malakots?
They can go for a Malicot, sir.
Yeah, it depends on the choice, whichever one you can use. What we're trying to say is it should stay in place for some time. So it's better to have some form of self-retaining stitch to hold it in, and the use of a self-retaining type prevents an accidental pull-out.
Yes, sir.
If you can do the drainage purely extra peritoneal, then it is good. All right.
Yes,
The mass, when you're treating conservatively and the patient has improved and he is getting ready to go home, what will be your advice?
So you'll ask the patient to avoid spicy foods and etc. Sir.
How does that make a difference, man? Does spicy food cause appendicitis?
No, sir. But it may be other. It can cause gastritis and any other complication, sir.
See, again, this is a problem. See, our gut is our nutrition. The moment the person is able to eat, he should be given his near normal diet, what he's used to eating, so that he builds up his protein and his immunity and his other status so to fight the infection. No.
Yes, sir. So
You
go for
allow
protein-rich diets.
diet as tolerated. Okay.
Yes, sir.
things you should avoid is smoking and alcohol, but the other is diet as tolerated. He can
Yes,
have it. So that, and you give him some antibiotics for some to cover the 5 days or 7 days period.
yes,
What will you tell him about his appendix?
sir. Already inflamed appendix, then it will be prone for easy rupture, so that to be careful with it, sir.
In other words, will you ask him to follow up with you for need for interval appendicectomy or not?
So it is it's according to conservative line of hospital from regimen, the internal appendicectomy should be advised, sir. But as per new criteria, it has been stated that recurrence of appendicitis is very less. See, if the patient is not accessible for any medical resources, you can go for appendicectomy, sir, internal
Correct.
appendicectomy.
Yeah.
If patient is available, I mean, medical resources are available for the patient, we can wait for the patient, wait for it.
What you have to tell the patient is learn to recognize early symptoms. Don't wait 10 days next time when it happens. If you get this
Yes,
kind of pain with vomiting, report early. You may need a
yes,
surgery. As you said, formerly we used to do interval appendicectomy for everybody who was treated conservatively. Yes, today's
yes, sir.
world, the studies say that it's not necessary, and that
Yes,
appendicitis essentially is a medical disease, and if it
yes,
can be treated with antibiotics and other things, the chances of recurrence is less than 10%. And
yes, sir.
if for that, you must tell the patient, follow up carefully, man. You must if you get this kind of pain again, please report to
Yes,
near. Okay. Is there any doubt or questions on appendicitis treatment, please, from anybody? Any of the people listening want to ask any questions? Okay, right.
sir, we
Now,
had an experience during the dengue period, sir.
yeah.
We had many cases with RIF mass turning to be dengue positive cases.
Yes.
So how can I explain the pain to dengue, sir?
If you're having a high fever out of proportion to your and a sick patient with low
Yes,
platelets in our
yes,
country, hepatosplenomegaly, mesenteric adenitis, and serositis are
yes,
all features of the dengue shock syndrome.
yes,
Okay, you have to be very careful. Don't knife them, please. They take off on you and they give a lot of trouble. Many times, this ultrasound people will say there is evidence of cholecystitis and
yes, sir.
gallbladder is infused.
Edema.
Then, yeah, the edema. Then they'll say appendix is well visualized and increased in size. Remember that in dengue, there is a reticuloendothelial reaction, and everything that has got lymphatic tissues and things will swell up and give symptoms also. So if you have a long story of fever and he gets
Yes,
right leg fossa pain, it is not acute appendicitis. It has
yes,
got something else. So be very careful. So the duration of fever and associated general symptoms will be much more than what the local symptoms are in the abdomen. Okay. So you have to
yes,
be very careful in this dengue situation. In our situation, it is very important not to get caught in that kind of appendicitis diagnosis. You
yes,
see, the physicians will always want to dump the case on you. Hey, you've got appendix, you take over. Please be very careful. Dengue is essentially managed by medical measures, and you do not get caught with a situation where you put a knife and the patient is actually dengue positive. So be very careful. Any other question?
Yeah, excuse me, sir. I just have a question regarding the management of the appendicitis. Actually, in my country, we never go for just managing it by antibiotic. We go for interval appendicectomy. We ask the patient to come after 6 weeks for appendicectomy, either laparoscopic or open. Although we know that appendix can be managed by antibiotic. So what can I do if the patient develop the same symptoms? I go to the theater immediately.
Yes.
And what is the chance of chronic appendicitis? It has a name, but I just forgot the syndrome. Chronic appendicitis. Thanks.
Yeah, thank you. Good question. I accept it. And please note that the interval appendectomy need is more clinical than compulsory. Many people, you can avoid it, but wherever it is necessary, it needs to be done. Why we say it is not directly recommended? Because it's not an easy surgery. There's a lot of adhesions and a lot of bowel damage and things can occur, and you find that it's not that easy to do an interval appendectomy, especially when there's been a mass and abscess and other things. So if it is developing symptoms, you have to do it very quickly. You give a trial laparoscopic approach. If you can get it, yes. Otherwise, you must be ready for a quick conversion to do a proper appendectomy in these cases. The standard teaching is, yes, advise interval appendectomy 6 weeks to 3 months later. But today, because of pressure of OTs and other things, unless it's necessary, don't do it is what is recommended. The compulsory need to do interval appendectomy is not so strong as of today. Okay, doctor, you followed?
Yeah, okay. Yes, I'm following, yes.
Yeah, okay.
Any chance of developing chronic appendicitis? What about this?
Sir, ma'am, there is no such condition as chronic appendicitis. It is only acute appendicitis or subacute appendicitis or no appendicitis. The old terminology of chronic appendicitis is now disputed. It was given as a reason for any pain in the right iliac fossa being labeled as chronic appendicitis, and appendixes were being taken out. It was more towards a remunerative reason for the benefit of the surgeon's pocket that these things were being done. Today, they say that the appendix is either acutely inflamed or not inflamed at all. The subacute appendicitis, appendiculolyth causing appendicular colic, and all that are being questioned. They are not compulsory indications for surgery. You treat it conservatively and leave it alone. The acute episodes becoming chronic is not there. Acute episodes have recurrent acute appendicitis. And so at one of those acute episodes, you have to take it out. All right?
Thank you very much.
Yeah.
Yes, thank you.
Now, since I have got a little, Dr. Patta, can I carry on?
Yes, sir. Please, sir.
Okay. Since there is a little time, I'll just move on a little bit. Okay. There are not many questions to answer. Now, I'm just going back into your differential diagnosis. Your second diagnosis was ileocecal tuberculosis. All right. Now, the ultrasound suggests a bowel mass, and there is evidence of palpable mass also. How will we will now ruled out appendicitis? Okay, which is going into another discussion. What is how will you confirm ileocecal tuberculosis? I can't hear. Your voice is gone.
Sir, can you hear me now, sir? Hello?
Yes. Hello. Not hearing, man. Audio.
We can't hear you properly, Isakki.
Yes, sir. Hello,
sorry, I cannot hear.
Sir, can you hear me now, sir? Sir, can you hear me now, sir?
No.
Hello? Hello, sir.
Okay. Tell me.
So now, sir?
Yeah, it's all
Hope
right.
it's okay now, sir.
Yes.
Yeah, sir. Can you hear me now, sir?
So how will you?
Hello?
Yes.
Hello, sir?
Yes.
Hello?
I can hear you. I can hear
Sir,
you.
I can hear you.
I can hear you. Hello.
Sir, can you hear me now, sir?
Yeah, I can hear you now.
Sir, good evening, sir.
Yeah.
Yes, sir. Sorry, sir. Sorry for
No,
the
no.
delay, sir.
Yeah, no problem. Okay. Now you found out, ruled out acute appendicitis and appendicular pathology,
Yes, sir.
and your suspicion of
Yes, sir.
right iliac fossa, bowel mass is there. It could
Yes, sir.
be tuberculosis, it could be inflammatory bowel disease mass, that is Crohn's disease. How will you proceed?
Sir, in case of inflammatory bowel disease, you can go for DMRD, sir. Hello, sir.
Sorry, you can
Hello.
go for?
Hello, sir. Can you hear me, sir?
Yeah.
Hello, sir. Can you hear me, sir?
Yes, man, I can hear you.
We'll go for biopsy and we'll confirm the diagnosis, sir. What type of inflammatory bowel disease it is, and we'll go for imaging to confirm the diagnosis, sir. Whether it is any Crohn's or ulcerative colitis, sir.
So tell me, what are the imaging findings that will make you suggest that it is inflammatory bowel disease or that it is
Imaging
Crohn's?
findings will go for, so in case of skip lesions will be seen in case of Crohn's, sir. And the involvement, GA can be involved. It can involve from the entire GA can be involved in case of Crohn's disease, sir.
Agreed. Okay.
And skip lesions will be found, sir. In case of ulcerative colitis, left colon will be affected, sir.
Yeah, but you don't get a mass in the right iliac fossa in ulcerative colitis. No, you get only in
Yes.
Crohn's disease. Yeah.
Crohn's disease, sir.
So how will you differentiate? What are the imaging findings that will help you?
You can go for CECT abdomen pelvis, sir.
Okay.
And ultrasound abdomen, both will be.
That we have finished. Ultrasound showed us is bowel mass, but he doesn't give
Yes.
more information. So now how will you move?
In case of, then we can go for colonoscopy, sir.
Here is a place where you can have an endoscopic approach.
Yes, sir.
And see for the lesion. If you are not having endoscopy available easily, we can still do the traditional contrast X-rays, either simple contrast, that is barium meal follow through, or a CECT if you have the facilities. Here you need contrast. You need contrast in the lumen of the bowel, and you need intravascular contrast so that you can make out what is happening.
Yes, sir.
Can you give me a few findings in the right iliac fossa that will tell you on imaging, either CECT or barium, that this is a case of tuberculosis?
So the presence of granuloma, C-setting granulomas may be present.
No, you can't make out granulomas on CECT. No.
So pulled up cecum will be there in case.
Correct. Why does the cecum get pulled up?
So
Hello, can you hear me? I asked a question. Why does the cecum get pulled up?
not sure about the reason, sir.
Okay. The reason is the hepatic flexure is a fixed point, and the inflammation of tuberculosis causes submucosal kind of fibrosis and narrows the area and pulls the cecum up towards a fixed point. That's why in tuberculosis you get a pulled up cecum. There are 4 findings that are very important. One is a pulled up cecum. 2 is a patulous or a loose ileocecal area with a constricted ileum at that point and a dilated ileum proximal to it. So a dilated ileum going towards a narrow fixed kind of ileocecal junction, along with irregularities in the cecal wall and on the ileal walls suggestive of inflammation, is the features that go in favor of a ileocecal tuberculosis. There are a couple of signs, they're called the Stirling sign and the Fleschner sign. You can read that up. They are, nowadays we don't use it much, but they're all evidence of right iliac fossa inflammatory pathologies.
Yes.
If you do a CECT, you will see bowel thickening, and you will see the presence of lymph nodes, and you'll
Yes, sir.
see the narrowing of the lumen, also associated with distortion and displacement of the cecum, which will
Yes.
give you features suggestive of ileocecal tuberculosis. Okay.
Yes, sir.
The final histological diagnosis is by colonoscopy and biopsy.
Yes, sir.
Okay. Right. Now it proves to you that this is a case of intestinal tuberculosis. What will you do? This chap has no evidence of obstruction, nothing. He is passing flatus and fluid, there's no obstruction, and he is also able to eat. So what will you do?
So we'll start anti-tuberculosis drug and we'll wait for it, sir. As there's
Can
no
you name
emergency
the
medical
anti-tuberculosis?
management.
What are the anti-tuberculosis drugs?
Sir, we'll go for category 1, sir. Rifampicin, isoniazid, pyrozinamide, and ethambutol, sir.
Okay. Can you tell me the doses?
Rifampicin 600 milligram. We'll go for it, sir.
Milligram per kg?
Sir, not sure about it, sir. Sorry, sir.
Okay. A little later, I will, if I have the time, I'll tell you all the little mnemonic to remember that. That's easy. Please remember, if you have tuberculosis today, it has to be reported to the government and the tuberculosis centers. You have to, TBAC studies have to be done, and bacterial studies have to be done. And these cases, even if it is extrapulmonary tuberculosis, they have to be reported to the government. So you cannot sit quiet. Once you get a diagnosis of tuberculosis, these cases have to be also informed to the local tuberculosis control centers. Okay.
Yes, sir.
Don't forget, in the exams, we'll keep asking you this because this is a government rule. This is a national rule of the revised RNCTCP program. So you have to inform every case of extrapulmonary tuberculosis also, because people are treating these things without adequate proof and causing tuberculosis resistance to come up, and that is a bigger problem for the national people. Okay.
Yes.
So we'll give anti-tuberculosis treatment. Can you tell me what are the indications for surgery in a case of ileocecal tuberculosis?
In case of any obstruction, sir, actually, the patient has to be obstructed.
Yes. Evidence of obstruction, yes. Hello.
Yes, sir. Can hear you, sir.
Okay, one is evidence of obstruction. Subacute obstruction features will be there, yes. Anything else?
The polyp formation, granulomas.
No. The usual indication is the, and or if any other acute episode like either a perforation or a bleed from this area occurs, those are very rare. They are indications for you to do surgery. But the main indication is the onset and non-relief of obstructive symptoms with conservative management. Then you have to go in and do some form of surgery.
Yes, sir.
Patient is showing subacute obstruction. He's not getting better with anti-tuberculosis. What surgery will you do?
So we can. So resection and anastomosis of the breech can be done, sir.
What is that? Resection and anastomosis. What will you resect? How much of ileum? How much of cecum? How much of ascending or descending transverse colon? What is the word used?
Right hemicolectomy.
Right hemicolectomy is a very extensive operation. Remember, you don't want to take out unnecessary bits of intestine. The answer is a limited resection of the right iliac fossa, limited resection of the ileocecal junction. That is, you take the cecum and the ileocecal junction and the ascending colon, you release the transverse, the hepatic flexure, and you take it, part of the ascending colon which feels normal is the level at which you remove it. Can tell me some more. When you do this operation at laparotomy, you find 2 or 3 tubercular strictures proximally. What do you do?
So assess the nature of the stricture. So if it is full thickness stricture or partial thickness stricture, sir.
Full thickness.
I'll go for resection and anastomosis of the local segments, sir.
Any other operation?
A dilatation of the stricture can be tried, sir.
Dilatation. What is that word I'm asking you for?
Okay.
Stricturoplasty. Have you heard of
Yes, sir.
stricturoplasty?
Stricturoplasty can be considered, right, sir.
How do you do a stricturoplasty?
Sir, let's make a vertical incision and suture horizontally.
You make a horizontal incision and
Sorry, horizontal incision,
Yeah.
and suture vertically, sir.
always remember you cut transversely and then you stitch it in an vertically, in the sense that
Yes.
you will increase the lumen size. You will not allow it to get further narrow. Okay.
Yes, sir.
That is a stricturoplasty. Somebody has written the Heineck-Mikulix type. Yes, that is the correct word. That's what is used in these
Yes, sir.
cases. Yeah, so you need not remove extensive bits of bowel just because there are strictures, and
Yes.
try to avoid too many anastomosis. You do a simple stricturoplasty wherever this stricture is giving symptomatic hold up of bowel content.
Yes, sir.
Okay, will you drain or not drain this patient?
So, a drain should be kept in this patient.
Okay, why?
So, to avoid any collections, and in case of anastomosis done, it will check for leak also, sir.
Yeah, the main thing is whenever you operate in lymphatic field, there will be an ooze, there will be a collection. So it's better it is drained, just like you do after MRMs, you do a drain into the axilla because of lymphatic work. Here also you would have interfered with lymphatics, there'll be some amount of collection. So it drains, as also a little precaution against a possible anastomotic leak. Okay.
Yes, sir.
Many people today are going against the drain, not necessary to drain, but so long as the patient is on antitubercular treatment, there is no harm in putting in the drain for these patients.
Yes,
The old thought that tuberculous peritonitis gives rise to a permanent sinus has now been defeated because your antitubercular drugs take charge and they help you to heal. So you can, the indication for drainage is individualized. If you feel that the dissection is extensive, you can put in a drain. If you are confident of your work and you have no doubt, you need not put a drain. All right.
Yes, sir.
Will you do this laparoscopically?
Stricturoplasty, yes, sir.
Yeah, today we can do this laparoscopically. These are all indications
Yes, sir.
that we can do. What is the difference between laparoscopy and open surgery in terms of operative steps in mobilizing the bowel? You understood my question?
Sir.
Hello?
Sir, I have
No, see, in open surgery, you open and you mobilize the bowel by cutting on the lateral
Hello.
paracolic gutter, and you mobilize the cecum from lateral to medial, isn't it? Hello? Hello?
Yes, sir.
Isakki, we can't hear you clearly.
Who, me, sir?
Yes, I can
No,
hear you,
Dr.
sir.
Isakki, yeah.
So that's it.
Sir, I can hear you, sir.
Yeah, you mobilize from lateral to medial, but when you do it by
Hello, sir.
laparoscopy, hello, yes, when you do it
Sir,
by
I can hear you, sir.
yeah, okay.
Sir,
So when you do it by laparoscopy, you mobilize medial to lateral. You first get vascular control. In the mesentery, you get your iliac colic artery and your right colic artery, and then you mobilize the bowel from medial to lateral. So that's a slight difference in how you mobilize bowel between laparoscopy and open surgery. Okay.
yes.
Can you take your screen off? I'd like to share my screen now, please.
Sure, sir.
You switch off your screen, Chairman.
1 minute, sir. I want. Yes, sir.
Have you
Done.
switched off?
Yes, sir.
Mm. Okay, just to go back on this case,
Yes, sir.
these are the little bits of teaching that I'd like you all to note. Remember, your patient presented with abdominal pain, and one of the nice ways to ask all the questions about abdominal pain is to use this little mnemonic called Socrates. Socrates was a very famous philosopher of ancient times, and the site of pain, onset of pain, the character of pain, and that in that character you will get the colicky nature of the pain and the radiation or the movement or the directions in which the pain goes, associated symptoms like nausea, vomiting, loose motions, distension, all that. How long does pain last when it comes, and what gets the relieving factors, exacerbating or relieving factors, and finally, how severe is it? Is it limiting his work, or like some pain, they can continue their work, but it doesn't limit them from their work. Remember, whenever there is vomiting, you need to ask for nature vomitus, like you rightly did. I was happy with that. These are all the features of vomiting. But when you have vomiting, always make sure you ask for weight loss, because vomiting is a state by which you lose nutrition. So if it is a long-standing vomiting, there will be weight loss. And it's fatigability. The patient gets very tired. So you need to get a performance score of his daily activity when you present the case also, especially if they give this history, okay?
Yes, sir.
If it's a lady, you must get detailed menstrual history. Of course, there are some histories of tuberculous contact. Be careful, ask very carefully. Many of them many people living in the same house. So you must ask carefully for that history. In the examination of the abdomen, remember, it's very simple. There are 10 little things that you have to look for. You see the shape of the abdomen and its movement with respiration, 2 things. You look at 4 fixed spots: umbilicus, flanks, hernial orifices, external genitalia. And you look for 4 fixed findings, like the presence or absence of a mass, peristalsis, veins, pulsations. Some people even say scars and hernial orifice and impulse on coughing and all that. If it is there, you mention it. But in a normal abdomen, these are the 10 things that are necessary to be mentioned in your presentation. And in the palpation, don't forget, you need to also palpate, feel what the first thing is, you must say is the abdomen is soft. Feel of the abdomen, and there is no tenderness. Then it gives us the idea that you are talking about a chronic abdomen, so that we can rule out acute abdomen presentation of anything.
Yes.
When you feel a mass, you have to describe it fully. That is your size, shape, extent, surface, borders, consistency, phlegm, and its mobility. Please note, specifically for mobility and other things, if it is in the upper abdomen, make sure you're able to insinuate your fingers between the mass and the costal margin or not. If it is in the middle of the abdomen, in the lumbar regions, you must make sure whether this mass is bimanually palpable or ballotable. Thirdly, in the lower abdomen, lower third of the abdomen, you must look and see if you feel that lower border, because sometimes these masses disappear into the pelvis and you're not able to feel a lower border. And when you are on the central abdominal masses, you must palpate for pulsations. Umbilical and epigastric masses could transmit pulsations, and they must be seen, looked for. Always remember, palpate for the solid organs of liver and spleen, especially liver, carefully, and the span of the liver. And don't forget 3 S's at the end of it. Look at the scrotum in the male. The spine, in this case, you didn't tell me much about the spine. This case, another differential diagnosis could have been a psoas abscess, which is lying over there, that could be presenting in this area. But there would have been no mobility. It will not be mobile. That's why I didn't take you into that direction. It will be retroperitoneal. And don't forget the supraclavicular lymph nodes. Again, if you look, these are also add up to 10 things about the mass and its presentation.
Yes.
Make sure you do percuss properly. Look for shifting dullness in correct way, as well as this liver dullness span and upper border, the percussion over the mass, and if the mass is in the upper abdomen, is there any band of resonance between the mass and the liver and spleen?
Yes.
Auscultation, not that one. Remember, internal examination is with consent of the patient, and please inspect first. Don't stick your finger into the rectal. Look for the fecal content, look at the mass lumen, external luminal, and fecal staining of the glove. And if necessary, in a lady, you may have to do the rectal exam, the vaginal examination also. In ileocecal tuberculosis, the differential diagnosis is these conditions. A carcinoma cecum, an appendicular mass. Today we went towards appendicular mass. You must remember Crohn's disease also gives rise to mass, but then you have more GI symptoms. You have more bleeds, you have mucus diarrheas, you have weight loss, and you have masses that come and go, intermittent masses. Ovarian cystin tumor in the female, iliac lymph nodes and mesenteric lymph nodes can come into right lower quadrants. A psoas abscess. Don't forget an unascended kidney. Sometimes kidneys are lying in the right iliac fossa and you may mistake it as a mass. And the true retroperitoneal mass, either of lymph nodes or of a malignancy. This is a little table that I'd like you to keep in mind, because these are the 3 common differential diagnoses of right iliac fossa mass. Ileocecal cox is a subacute presentation, appendicular mass is an acute presentation, and CA cecum, older person with a relatively insidious presentation. The present as the different symptoms and mass findings are also given over here. When you have a mass which is hard and fixed, and there is, it is more in favor of a carcinoma of the cecum, and these are the other features. If you start antibiotics and it reduces in size, you know it is appendicular. But if it's ileocecal, it will remain the same. And if it is cecum also, carcinoma, it will remain the same. Radiological signs, I told you there'll be filled up cecum, altered ileocecal angle, dilated ileum, cecal and colonic filling defects, various little names given to it, Frischner sign, Sterlin sign, you'll all see that. In appendicular mass, you don't get specific signs, but in the CA cecum, it is irregular filling defect of a normally placed cecum, and in them, they will have raised tumor marker levels of CEA. This carcinoma embryonic antigen will be raised. How do you confirm? You do your regular tests that you do. If you have ascites, you can tap and check for your ADA, your protein, your acidic blood glucose ratios and other things. These are all the tests that can be done on acidic fluid if it is there to get a diagnosis of tuberculosis. MAN2 is non-specific. Colonoscopy and biopsy is one way of getting it. Failing that, you may even have to do a diagnostic laparoscopy and a peritoneal biopsy to get actual histological proof for tuberculosis disease. When do you ask for a CT scan? A CT scan is asked when you have a fixed mass, when you suspect multiple sites of involvement of bowel, like in Crohn's, when you want to assess the lymph nodes, and sometimes in some forms of preoperative planning. Colonoscopy gives you the tissues for histopathology. It rules out carcinoma. And also, if it is malignancy, it rules out other synchronous lesions in the colon. Ultrasound, yes, there is bowel thickening. You can see that the wall of the bowel is thickened, and you may find the nodes being hypoechoic with central and peripheral hyperdense rims, what they call as the halo signs. Very meal follow through these. I told you the Stirling and the Fleschner signs. This is something like that. You have a pulled up cecum, distorted filling defect, altered ileocecal junction, dilated ileum on either side, collapsed kind of up ascending colon, which suggests the tuberculous pathology. In CT scans, you can see that the bowel is thickened over here. Can you see the lumen is narrowed in the right iliac fossa, very classical of ileocecal tuberculosis. You can see the filling defect in the cecum over here. And you can see the narrowing of the lumen with all circumferential thickening, all features of ileocecal tuberculosis. The lymph nodes, they get enlarged with this rim or a halo-like sign over there, and they can be heterogeneous. There'll be multiple lymph nodes all over, and that is suggestive of tuberculous pathology. Some of these lymph nodes can come together like a mass. You can see that this mass is close to the umbilical region, and it can present right or left side as a palpable mass. What are your management decisions? Your management decisions are, do we do surgery or not? The indication for surgery is the presence of subacute obstruction or intestinal obstruction, and you do a limited resection, a limited colectomy, and very rarely do you need the formal right hemicolectomy. Stricturoplasties and ileocecoplasties are sometimes even the ileocecal region, they widen by a local procedure without resection. The importance is that you try to conserve intestine in all these people. Where you have a mass with no obstruction, you give a standard 4-drug regime of isoniazid, rifampicin, ethambutol, and pyrazinamide, and I'll give you the dosages of that. What questions do we ask you? If you've reached this level of discussion, the questions asked you is will you do open or laparoscopy? If we open, what incision will you use? Vertical, paramedian, midline, or a transverse incision over the right lower abdomen? Resection, how much will you take out? What form of anastomosis will you do? Will you do hand sewn, single layer, double layer? Or will you do stapled? What is the material you'll use? Will you put a drain or not? That some people say yes, some people say no. Will you give preoperative bowel preparation? Today they say that is not necessary. If the patient just passing motions, make sure he just empties his bowel. And the intraoperative antibiotics and the antituberculous cover that is necessary. Here's a case where there is an ileocecal stricture, a stricture just proximal to the ileocecal junction. There's another stricture over here. So stricturoplasties with the resection of that area was done. This was stricturoplasty, this was resected. What are your complications? The complication that come up is the anastomotic leak, where 3rd or 4th day you find there is fecal discharge from the drain or from the wound. In some cases, when you do very extensive mobilization of the colon, there's a chance that you may injure the 2nd or 3rd part of the duodenum, retroperitoneal, and you have a leak of bile, and that's a big problem to handle. Very rarely, but I have seen this happen. My intern came running to me in the night and said, sir, there's more than 1 liter of water in the drain bag. We went back and had a look and found that it was a ureteric injury. And there was a divided ureter over there. You approach it by doing a cystoscopy and stent it. If you can stent it, it treats it for the time being. If you cannot stent it, you may have to go in and do a nephrostomy or something to get that leak, urine leak controlled. A problem that occurs in many of these patients is very long ileus. They take a long time for bowel sounds to return. And so you need to be watchful for that and treat conservatively till it comes. There are no specific treatments, it just settles down. Abdominal tuberculosis, there's peritoneal type, there's intestinal type, there's lymph node type, and there's genitourinary type. So you'll always be asked, why is ileocecal area involved? Why cecum gets pulled up? What are the types of intestinal tuberculosis? Ulcerative, hypertrophic, fibrotic, ulcerafibrotic, and differences between the ulcerative and the hypertrophic varieties. This is what the questions that can be asked. General questions about tuberculosis. Some people may ask you, how do you classify mycobacterial tuberculosis? The rapid growers and the niacin positive versus niacin negative types of classifications, the atypical growers. Classify anti-tuberculous drugs. You'll have to know the regimes that are given under the DOTS programs. Doses and side effects of the drugs. Easy mnemonic to remember is 5, 10, 15, 20, 25. Isoniazid is 5 mg per kg. Rifampicin is 10 mg per kg. Ethambutol is 15 mg per kg. When you're using streptomycin dose is 20 mg per kg. And pyrazinamide is 25 mg per kg. So it's a very useful little classification remembrance per kg dosage, and you'll be able to calculate the dose depending on your. Other questions that they ask you is they ask you what's an abdominal cocoon, and encapsulating peritoneal sclerosis that kind of catches up all the intestines into a little ball. They'll ask you why you get matting in lymph nodes. You know that is due to the periadenitis. And they always ask you why the cecum gets pulled up, and I told you it's due to the submucosal, subserosal fibrosis that pulls the cecum towards the fixed point of the hepatic flexure. That's a little brief on what happens when you get a right iliac fossa case. You can either get discussions on appendicitis, management of appendicular lump, drainage of appendicular abscess, or an ileocecal case where you can get the discussions on how you come to the diagnosis and how you treat and how it goes. I purposely did not involve myself in a carcinoma cecum discussion because it's a big topic. Carcinoma colon is a big topic. There's a lot more things to do. And are you with me, doctor?
Yes, sir. Yes, sir.
What's
you,
the
sir.
difference between para-aortic lymph nodes and pre-aortic lymph nodes?
Sir.
Anybody who's listening, can anybody come in? Okay. Para-aortic lymph nodes are the lymph nodes alongside the aorta on the left and right side of the aorta related to the paired blood vessels, to the renal arteries, to the suprarenal arteries, and to the lumbar arteries. Whereas pre-aortic lymph nodes are the ones related to the visceral and single arteries, either inferior mesenteric, superior mesenteric, or celiac axis groups. So these are the lymph nodes that come. When you talk of abdominal pathologies, your lymph node drainage from the bowel is paracolic, epicolic, paracolic, mesenteric, and pre-aortic lymph nodes. When you talk of testes and gonads and Hodgkin's and other things, the drainage is to the para-aortic lymph nodes. Both these, pre-aortic and para-aortic, are felt in the midline, difficult to distinguish clinically, and always felt above the umbilicus, not at the umbilicus and above. You don't get lymph nodes in the midline. That will be suggestive of this group below the umbilicus. Right, is there any more questions? Dr. Patta, sir, is that enough? Is it okay?
Yeah, fine, sir. Fine, sir. Any questions from the audience? Any more questions before we conclude the session? It's a brilliant lecture, sir. Very clear and very informative, as always. Thank you so much for spending time with us.
Sir. Yeah. Any other questions to be answered, sir, in the chat box? Ultrasound and documentation. Yeah. Okay. No more messages here. Okay, somebody said thank you for the presentation. Yeah. All right. Thank you. Good night.
Thank you. Thank you so much, sir. Have a nice week ahead.
Yeah. Thank you.
Thank you, sir. Thank you very much, sir.
Thank you, Isakki.
Hey, for your presentation, you pass. Huh? This will you'll get through. Don't worry.
Thank you, sir.
If I
Sir,
am
one
your
more
exam
extra
madam,
doubt, sir.
yeah, don't worry, but you need to
Sir,
be.
whether the yes,
Sorry?
sir, one doubt, sir. Sir,
Yeah.
whether the COVID thromboembolic manifestation of COVID-19 can also present as acute pain in RIF, sir.
It can present as anything, man. Honestly, I have not been working because I'm above 65, so I haven't seen many COVID cases with acute abdomen. But it seems there are abdominal presentations. I have not seen. And if it presents, if he's got a COVID positive status, all the more reason you will go only conservative. I don't
Yes,
think you will risk yourself operating these cases. Just wait for it. Okay.
yes, sure.
Okay.
Thank you,
Thank you very
sir.
much.
Thank
Thank
you
you,
once
sir.
Thank
again.
you, sir.